Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of Northeast Studio in Fall River, Massachusetts. Today we'll be discussing endocrinology surgery with Dr. Peter Mazzaglia. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, by following us on Facebook and Instagram. And also, please remember to leave a review, and 5-star reviews are always greatly appreciated. All right. So, I've known Dr. Mazzaglia for many, many years. As a disclaimer, we went to school together. And I'm really happy to have you here on the show. And why don't you start by telling your audience a little bit about yourself?
Sure, yeah. Yeah, Chris and I go way back to med school at UMass in Worcester. And we graduated in 93, right?
Right, correct.
Yeah. So over 30 years. And so I ended up becoming a surgeon through a sort of a circuitous path, but I became a general surgeon, and then I specialized in what's called endocrine surgery. So it's not something that a lot of people are familiar with, and it gets confused frequently with endocrinology, right?
Right.
So endocrinology is something most people are familiar with, because
Correct.
endocrinologists deal with things like diabetes and thyroid problems and adrenal problems, pancreas, etc. Hormones, right? Endocrinologists deal with hormones. But what I do is surgery on some of those endocrine organs. So I'm an endocrine surgeon, and the three organs I primarily operate on are the thyroid and the parathyroid, which are these little glands next to the thyroid that regulate your calcium, and then the adrenal glands, which make a whole bunch of hormones, and the adrenal glands are, right on top of the kidneys. So that's my primary focus. I do some general surgery still, gallbladders and hernias, but I'd say 85% of what I do is called endocrine surgery.
What was it that really interested you in endocrine surgery over other types of surgery, per se?
Right. Yeah, that's a great question. So I mentioned how I had a sort of circuitous path. So when we graduated from medical school, both Chris and I became internists. We became primary care docs. And I did that for 3 years. And then I just really missed the operating room and the whole surgical discipline. And I went back and did another 5 years of training.
You're really a glutton for punishment.
Yeah. So yeah, it was a little bit tough at the time. I'll be the first to admit it. So I had this big background in internal medicine. How to treat people with medications, et cetera. And then, so this little field within general surgery, endocrine surgery, carries a lot of medical, aspects to it. So managing thyroid disease and working up adrenal problems and dealing with all the hormonal testing and management of that. And it's kind of sleuthing things out. So you're not just a technician. You're assisting primary care docs and endocrinologists in figuring out what exactly is the problem, and then determining, okay, is this a problem that I can approach surgically, or is it something in the realm of the endocrinologist and it needs to be managed medically? So that was the big appeal. And then another nice thing about my field is that the patients do well. They're problems that you can operate on them, and they have good outcomes. Like people who have thyroid cancers, they do very well. So it makes my life a little bit more fun. And so those were some of the.
And there aren't a lot of you around. I mean, it's a very specialized field.
Right,
so.
right. started my practice when I finished my training at Cleveland Clinic. I started my practice in Providence, and I've been there now for 19 years. And I have one partner, but we're the only two endocrine surgeons in Rhode Island, and there is an endocrine surgeon in the Fall River area, but it is something that's quite rare, actually.
Okay.
Why?
Why? Because
Because of all the schooling?
you don't need a lot of us. You know,
Okay.
yes, there's a lot of thyroid disease, and I do many operations, but there are a lot more hernias and appendicitis and gallbladder attacks.
Sure. That's way more common.
Yeah. So a few of us can sort of cover a big area.
Okay.
With the general health and, just in this area in particular, the cardiac disease, the obesity, and all those factors, does that factor into increasing rates of how many people need surgery, or is that there's no correlation with that?
So for things like thyroid disease and parathyroid disease, the people who have heart disease or diabetes, they don't have higher rates of having thyroid disease. But there is a very high rate of thyroid disease in the community. People that have, and a lot of them are conditions that are managed medically.
Okay.
Say like Graves' disease, which is a condition of the thyroid where you have too much thyroid hormone. And initially you can lose a lot of weight. Those are the people that sometimes you can see their eyes are bulging a little bit. So those people would be managed by an internist or an endocrinologist like Chris initially, and then stabilized, and then for some more, like a more definitive treatment, they might come to me to have their thyroid removed. So I guess the short answer to your question is there's not a huge correlation between heart disease, diabetes, and obesity, but there are some relationships. A lot of people think, oh, I'm obese, I must have a thyroid problem. You get that a lot, and some of them do, but a lot don't.
So, what's the break point from being managed with the thyroid, parathyroid, anything going wrong with the adrenals? What's the break point from being managed, like what Chris would do, maybe, or
versus surgery?
Right,
Probably
exactly.
have to separate it between thyroid, parathyroid, and adrenal to do that.
Right. So let's start with thyroid because that's by far and away the most common.
Exactly.
So thyroid. A lot of people have nodules on their thyroids.
Okay.
They're also called goiters. You think of a goiter when someone has a big nodule and you can see it sticking out. But any thyroid nodule could be called a goiter. Well, up to 50% of people have some kind of a little thyroid nodule. And then when they're picked up by your primary care doctor at an annual physical. Sometimes the patients will feel them.
Okay.
And then a lot of them are picked up when they go and have some other scan, for like a carotid ultrasound or a CAT scan of their neck.
Yeah. So it's like an incidental finding.
It's an incidental finding, but then it needs to be evaluated because about 5% of the nodules will end up being thyroid cancers. So those are the patients that we have to evaluate, and often they'll need a biopsy.
Right.
So if there's a question on a thyroid biopsy of the patient having a thyroid cancer, that would be a patient that would come and see me.
Okay.
And the biopsy is often done by a needle biopsy, and then they get a diagnosis, and then they would go to you if it was malignant.
Right. So the biopsies, once you find a thyroid nodule, you have to do some blood tests. And then if you decide, okay, this is a nodule that should be biopsied, in general, there are about three different types of doctors who might do that biopsy. One would be a radiologist, one would be an endocrinologist, and one would be me, an endocrine surgeon. So I'm getting patients coming from all different angles. So some of the patients will come to me, they've already had their biopsy. But some of them come to me and their primary care doc said, hey, you've got this nodule. I'm going to send you to Peter, and he'll decide if you need a biopsy or
Would
not.
there be a difference between the way the biopsy was done between a radiologist versus an endocrinologist and an endocrinological surgeon?
I mean, there are fine differences, but the basics of it are that we use the ultrasound probe
Okay.
to image the nodule and localize the nodule. And then as we're doing the biopsy, which is in my case, it's done right in my office. So frequently I'll meet you for the very first time and you're coming to see me about this nodule. I'll talk to you and examine you and then ultrasound your thyroid. And based on the history and what the nodule looks like on the ultrasound and how big it is, we'll decide, okay, this needs to be biopsied. And then we'll go ahead right there and do it. And it only takes a couple minutes. It's a couple quick needle sticks. And we use the ultrasound to follow our needle so we know exactly where we're going and we can be very accurate.
So I just want to highlight that statement because as a patient who would have high anxiety even, so here I am walking into your office thinking all this stuff going through my head, instead of having another procedure, you're a doctor that can do the surgeon performed ultrasound. So can you just talk a little bit about that? Because that is very beneficial to me.
Directed ultrasound?
Well, just the ultrasound, so you're looking at and not reading something that a radiologist gave you a report on. You're seeing it.
Right. So,
and it's not, everyone doesn't do this.
Right. So the ultrasound is part of, fortunately, the training I got when I went away for a year to Cleveland, to the Cleveland Clinic. We did ultrasound on every single patient in the office. Then we did their biopsies, and then in the operating room, after the patients go to sleep, we ultrasound them again, so that right before we start operating, we have another image right in our mind of exactly what we're going to go do. So it was ingrained in me to do ultrasound. So I would be I wouldn't be uncomfortable, but I would feel almost naked if I didn't have my ultrasound when I'm evaluating patients, because it's just like opening, a picture paints 1,000 words, right? I know exactly what I'm doing because I know what's happening in there. The ultrasound creates this beautiful image of what's inside your neck, your thyroid gland, lymph nodes, parathyroids, everything, blood vessels. So you talk about patient anxiety. So it's funny when patients come in and I'll evaluate them and do the ultrasound, and then I'll say, yeah, so this needs to be biopsied. And so they'll say, well, you're going to do it right now? And I said, yeah, it's just going to take us a couple minutes. We'll do it. And it's usually much better for them because they don't have time to fret about it.
And they don't have to go schedule it.
Then they're done.
Yeah.
And it's much easier. And
I like that.
It works out, for most people, it works out well. And many of them say, I had the biopsy done somewhere else before. I've had it, this is my second time being biopsied. And usually it's a little bit smoother. For whatever reason, it goes very smoothly.
Right.
Yeah.
If someone put off treatment, how long are those images and biopsies good for? Or when would you rebiopsy?
So thyroid nodules, the vast majority of them grow very slowly.
Okay.
So, but if I keep my images, in the record for forever.
Right.
And if say you came to me with a 3-centimeter thyroid nodule and we biopsied it and it was benign.
Okay.
And it wasn't bothering you. Some people, the nodule bothers them. They feel it when they swallow. It's uncomfortable. Or they can see it, or other people see it. So in those cases, even if it's benign, we may end up taking it out. But say it was benign and it didn't bother you at all, then I would tell you, you need to have an ultrasound next year just to make
Okay.
sure
Okay.
it's stable.
Nice.
And you might come to me to do it, or you might just go back to the radiology department and have it done. And then once you establish that it's stable, after that year, if it really doesn't change, you don't have to have these ultrasounds
Okay.
every year.
Okay. Nice. So that's the thyroid. You also talked about the parathyroid and the adrenal glands. Is the process any different, or are you looking
Well,
a little differently at
Sure,
those?
sure. Well, the diseases are completely different.
Right.
And things get a little jumbled because most people haven't been educated about what a parathyroid is.
Exactly.
So
True.
they might think you're just talking about their thyroid. So the parathyroid has nothing really to do with the thyroid.
Okay.
It just happens to live next to the thyroid. And there are 4 of these little parathyroids in your neck, 2 on each side, and they're kind of behind and below the thyroid.
Okay.
And they're tiny. We tell people they're the size of a grain of rice, and they literally are when they're normal. And they're often difficult to find. They can look like a little piece of fat or a lymph node. And so the thyroid, just to backtrack a little bit, because we were talking about the thyroid makes thyroid hormone, and that regulates your metabolism.
Okay.
The parathyroids have nothing to do with your metabolism. They control your calcium level.
Okay.
So the condition of the parathyroid that gets people into my office is when they have a condition called hyperparathyroidism. They have
Okay.
too much parathyroid hormone, and it's usually because there's one rogue parathyroid in there that just decided it's going to grow too much. It's not a
Okay.
cancer,
Okay.
but it's an out-of-control parathyroid, and their calcium level climbs above what it's supposed to be. So Chris sees patients like this, and when you have this condition in the high calcium, the calcium is coming out of the patient's bones. So if left untreated, it can lead to osteoporosis and fractures, and then all that extra calcium is being filtered into the kidneys. So those patients are prone to kidney stones. And then there are a whole bunch of other potential symptoms that they can develop, like fatigue, brain fog, muscle aches, bone pain, constipation, acid reflux. So many people have these symptoms and they don't have hyperparathyroidism. So, it's a little hard sometimes to tease it out. But the diagnosis is pretty easy to make most of the time based on blood work and a urine sample. So,
Chris, those symptoms are kind of vague, right?
Right.
Like if I'm your patient, I might not tell you how I've been tired. I'm thinking, oh, I worked hard at my job or whatever, like I can probably assimilate all of those like symptoms to something else that I wouldn't necessarily
I
tell
think
you.
90% of the time we find this because we find a high calcium on lab work. That's what I find.
How often do you draw calcium on
Well,
patients?
it's part of like a basic metabolic profile. So,
Okay.
Is
that yearly?
well, no, it depends on the diagnosis. I mean,
Okay.
there's so many patients that say, for example, have hypertension out there.
Okay.
They're getting a basic metabolic panel on an annual basis, or someone's
Okay.
on a diuretic or whatnot.
Okay.
So you pick up a lot of this with that,
Okay.
or they have osteoporosis. That's another
Okay.
reason. So
Okay.
you do a workup for that to make sure that there's not a issue with hyperparathyroidism. So, they're going to get a calcium, a parathyroid level, a vitamin D level. But that's how a lot of this stuff is picked up. I mean, sometimes you have symptomatic hypercalcemia, and that does
Right.
occur. But I'd say most of what I see is asymptomatic.
yeah.
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 I mean, you might see more symptomatic because they're
Well,
coming to
because
you.
I asked them all those questions,
Right.
and most people say they have some. I mean, 90% of people say they're tired,
Right.
or
They're
they're
just such
achy.
vague symptoms.
Right.
Right. It is
Exactly.
vague, but if you have so yes, the vast majority of people, it's picked up when their primary care, does some blood work and the calcium's high, or they go to the ER for another problem and the
Right.
calcium's high. The ones who should be screened are people who have osteoporosis who
Yeah.
you wouldn't they shouldn't be
Definitely,
having
right,
osteoporosis,
right.
or anybody who shows up with a kidney stone should be screened for this.
That's absolutely true. Yeah, those are the ones that we really think about a lot.
But they're
Screen.
more the minority. The majority are. It's like the thyroid nodules. It's incidentally found.
Right.
But a lot of people, you ask them the questions. Well, yeah, I've been tired, and then you operate on them, and they say, "Oh gosh, I didn't realize."
Right.
Yes.
Because I've been feeling this way for a few
Right.
years.
It's very
Yes.
insidious, right?
That's been a common theme with a lot of
yeah.
podcasts. Like people don't
right.
realize how good they can feel.
They adapt. It's
Yes.
insidious. It happens very slowly. It's like I see this all the time with patients who have cataracts, and they have their cataracts out, and they say, "Oh my God, I didn't know my vision was so bad because it
Right.
happened over years."
Exactly.
Yeah, it's a lot of medical conditions such as that.
So I'm going back to our four little friends where one's rogue.
Yeah.
So is it size that you know which one is
Right.
rogue?
Yeah. Yep.
Okay.
It's size.
Is it easy to visualize that?
It is if you know where to look. They're bigger, they're darker in color, they're firmer, and then we have ways of figuring out which is the bad actor before we go to the operating room. So there are a couple. One is ultrasound. So very interestingly, they're so small that if I did an ultrasound of you, presumably yours are all normal, I wouldn't be able to see any of them.
Oh.
We can only see them when they get enlarged.
Oh,
But then when they
okay.
get enlarged, if you know where to look, it's not hard to see them on the ultrasound. And the other test that's been around forever is a nuclear medicine scan called
Okay.
a parathyroid scan or sestamibi scan. That's a very common scan to do.
Yeah.
And you can also use CAT scan, but I just use that in more complicated cases. So I do the ultrasound on everybody if they haven't had anything before they come to me, but everybody gets an ultrasound. And if I see it on the ultrasound, then I don't send them for any other tests. If they need the operation, then we just discuss it and plan the operation. And all these operations are mostly outpatient.
Oh,
The
great.
thyroid operations and the parathyroid operations. Yeah.
So now,
Go ahead. I was going to just
Sorry.
ask a question. I've never seen this, but do you see parathyroid malignancies?
So I can count them probably on one hand in 20 years that I've been in practice, parathyroid cancers. They're just so rare.
Right.
If you read the textbooks, it's supposed to be 1 or 2% of people with hyperpara have parathyroid cancer, but it's much, much
I've
less
never
than
seen
that.
it, so I was
It's
curious.
incredibly rare, thankfully.
Yeah, thankfully, right. So I want to take a step back before we get into adrenals, which is probably where we're headed next, unless you have more parathyroid.
no, I
questions.
wanted to know what the bad influencer does, but go ahead. That
Okay,
little
well, I
rogue
just wanted just to
person.
summarize a little. So for the thyroid, you're dealing with thyroid nodules that
Right.
you would do surgery on and work up before. Goiters, which
Right.
we can think of as like a bunch of nodules or an enlargement of the thyroid. I guess patients who have Graves' disease who maybe failed treatment in some way.
More and more Graves patients are getting sent
Okay,
for thyroidectomy.
okay.
As you know, like half of the people with Graves, they'll go back to normal after
Sure.
1 or 2 years of medicine. And then if they don't, you could either give them radioactive iodine or surgery. More and more endocrinologists are sending them for surgery because it's guaranteed to cure
Sure.
them. And if they have what's called Graves' eye disease, where the eyes are bulging forward, they cannot get the radioactive iodine because it could make that process even worse.
Okay, interesting.
So those patients are referred for surgery. So I think what you were getting at, like, what are all the thyroid conditions?
Yeah, and
that
then
I
thyroid
operate
cancer,
on?
I guess. And
Right.
Is there anything that we're missing here? Or are those the main ones?
Those are by far and away the goiters, the nodules that we either don't know if they're cancer or we know they're cancer and they have to come out, and Graves' disease.
Yeah. And then you've got, for the parathyroid, it's really parathyroid, hyperparathyroidism.
Just enlarged parathyroid,
There's
yeah.
not much else.
Right. People who have kidney failure and are on dialysis, they develop parathyroid problems, but that's a whole nother
Sure.
class of patients. So the majority of parathyroid operations I'm doing are just ordinary people, their calcium is elevated, or they had a kidney stone and they find out that their calcium's high. And then most of them have one gland that's enlarged. We take them to the operating room, remove that gland. We actually see the hormone level drop 10 minutes after we get the gland out. We're measuring the hormone level during surgery, and it comes down to normal. So we have that confirmation. If in cases where it doesn't drop, then we know, oh, there must be a second gland hiding somewhere.
Okay. Oh, that's
we need to
interesting.
Yeah,
keep
that
going
was my question.
and
Yeah.
find
Yeah.
it.
Okay. Well,
Yeah.
that's fascinating. And you can, there are times you take out 3 of the 4 glands, or?
There are times we take out 3.5.
Okay.
So 5% of patients who have this problem, all 4 glands are enlarged. And we
Oh,
take out 3.5 of them.
okay.
Yeah.
All right.
Yep. And you'd mentioned vitamin D before. Vitamin D plays a huge role in calcium metabolism and parathyroid disease. So many of us in New England, especially because we're inside all winter long, we're vitamin D deficient. So we have to make sure that the vitamin D is, that we're accounting for that.
Yep. Absolutely. And now we're putting on our sunscreen, which we should in the summertime, and now we're even more vitamin D deficient, right? Yeah.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So, when you're doing surgery, this is just a quick little tangent question. Is it robotic assisted, or are you going in there?
We're going in there. Yeah. It's not
It's not that type
robotic.
of surgery where you would.
So the incisions are so small.
Okay.
For a parathyroidectomy, you could do the operation through a 1.5-inch incision.
All right.
And then a thyroidectomy, it's 2 to 3 inches for most of them.
Okay.
So it's just a very small incision, and we are very careful to find a natural skin crease
Nice.
and put it right in that skin crease. So I would say 85% of people, if you didn't look closely 6 months later, you would never see where that scar is.
Okay.
So very few operations are done robotically. There are places where you could go, centers, and have a robotic thyroidectomy, but unless you're a movie star, it's usually not necessary.
Okay.
It doesn't add too much, really.
Right. It doesn't. It's not a better operation. It's just if someone insists that they're not going to have a
Right.
little scar here. But honestly, the vast majority, you have no idea that they have it.
Okay.
Is this these procedures that used to be done like up in Boston and now are done more locally?
No. I would say that's not the case. They were surgery. The way that surgery has evolved, most surgery 50 years ago was done by general surgeons. So
Okay.
these operations were done by surgeons who did everything.
Okay.
And over the decades, we've become more and more specialized. So they were done here, but there was no such thing as an endocrine surgeon 50
Right.
years ago. So now they're primarily done by endocrine surgeons and ENT surgeons.
Okay.
Yeah.
Okay. Do you see a higher prevalence in like males versus females for these types of disorders?
Yeah, it's the opposite. A huge prevalence in females
Okay.
for both thyroid disease and parathyroid disease.
Why?
I don't know why you were cursed with all of these things, but women.
Well, we got the heart disease. Although women
Is
get a lot of
that- I
heart
don't
disease. I can't
know.
really
I
say
don't
that
know.
anymore.
women,
We think about that, but women have just as much heart
yes,
disease. Probably.
yeah,
Yeah.
no,
Yeah.
women are
They do.
somehow cursed with thyroid disease. 85% of it is in
Oh.
women.
Okay. Yeesh. So then going on to the adrenal glands, can you talk a little bit about that and
Yeah, sure.
what that looks like for surgery?
Yeah, so the adrenals, of the three, the adrenal's probably the most complex.
Okay.
So the adrenal glands are these two little glands. I mean, they're the size a walnut, perhaps, is maybe to give you an idea. And they sit, two of them, one on top of each of your kidneys.
Okay.
And they're just these little golden colored, they look not much different than fat. But they're making all these super important hormones. They make four main hormones: cortisol, adrenaline, a hormone called aldosterone, which controls your blood pressure and your potassium, and it could be causing high blood pressure if you're making too much of it. And then they make some of the sex steroids like estrogen and testosterone, mostly estrogen. So if there's some problem with the adrenal gland and it's making too much of any of those hormones, you can develop some major problems. But of the three, organs that I treat, thyroid, parathyroid, adrenal is the least common. They're very uncommon to have problems with the adrenal. And then the last thing that can happen with the adrenal, and thankfully it's very, very, very rare, is an adrenal cancer.
Okay.
And some other cancers can go to the adrenal, like it could metastasize.
Yeah, I was just going to ask you, are these like more primary site cancers, or are they like the adrenals? You have that.
Right. The thyroid is primary. Basically, almost nothing metastasizes to the thyroid, and the adrenal is the opposite. If you get a cancer in the adrenal, it's usually a metastasis and not a primary cancer.
Okay.
But the majority of adrenal disease I see are maybe adrenal nodules that we don't know if they're cancer or not. And biopsies actually aren't good to figure that out. So sometimes we have to just take them out. And that's based on the size and how they look on a CAT scan. And then any of them, if they're making any of those hormones, they need to come out. And that one is done laparoscopically.
Okay.
So that one is not a big incision.
Okay.
That one is done with a camera and either 3 or 4 little incisions, kind of like a gallbladder would be done.
It's a pretty involved workup, though, too.
Yeah,
to look into the adrenal
Right.
hormonal axis.
Right. It is the most complicated of the workups because you're testing for all those different hormones, and there's a lot of variables that go into it.
So for your adrenals, is that on a larger person? Is that harder to use your ultrasound to pick to look at those?
No ultrasound.
No
for
ultrasound
adrenals.
on the adrenals.
Yep.
Okay.
So for adrenals, you can either get a CAT scan or MRI, but mostly I rely on CAT scans.
Okay. All right, that makes sense.
Yep. No ultrasounding. Sometimes we use, when we're operating and we're looking for the adrenal and it's buried inside a lot of fat in there, we'll use an ultrasound inside the body to find it.
That makes sense.
But that's the extent of the ultrasound.
Is that common that
use.
it's hard to find the adrenal?
Sometimes.
Really?
Sometimes.
I think the kidney would be, pretty present.
Yeah, well, the kidney's not hard to find, but then in a more obese person,
the adrenal gets
the
lost
adrenal
in
might,
the
especially
adipose.
someone with something called Cushing's disease.
Okay.
So Cushing's disease happens when a little growth on the adrenal is making too much cortisol, and that just makes you put on weight like crazy because you could basically not be eating, but that cortisol is making you store every calorie you eat gets stored as fat.
I hate cortisol.
And so it can ruin your life, literally, and cause all kinds of other problems like high blood pressure, diabetes, and osteoporosis. So we're actually learning that more people have this condition than we used to think. They have little nodules in their adrenals, and they are making too much cortisol when you do the special blood tests. So I am seeing more of this kind of patient being referred to me to have their adrenal removed. And then when you get rid of that excess cortisol, that patient can have a dramatic weight loss. But I mean, these aren't common conditions,
Right, right, of course.
But-
So we had talked briefly about cancer with the thyroid, the parathyroid, the adrenal. These are still staged according to like stage 1, stage 2, stage 3, stage 4. And when you're dealing with like a stage 4 versus a stage 1, is it kind of like a oh boy moment? Like when you go in there, like what are you seeing?
Sure. What a great question. So for thyroid, this is going back to why did I choose to go into this? This is part of the reason. For thyroid cancer, if you're under the age of your age has a little bit to do with how well you're going to do.
Okay.
And if you are under the age of 50, you can't even be a stage 4 because the prognosis is so good.
Wow.
So we don't really talk a lot about stage with thyroid cancer
Okay.
because 98, 99% of people do great.
Okay. Perfect.
Even if you have a more aggressive thyroid cancer, stage 3 or 4. And so one of the common things with thyroid cancers are that they go into the lymph nodes in your neck. They metastasize. And if they're in the lymph nodes in your neck, that becomes part of the operation, cleaning out those lymph nodes.
Okay.
So those patients that have that more advanced thyroid cancer, they have a higher risk of having the cancer come back.
Okay.
But when it comes back, it usually just comes back in the neck.
Okay.
So the thyroid cancer patients I see them every year,
Okay.
and I ultrasound them every
Nice.
year.
Okay.
And then if we find that it's back in another lymph node, we have multiple ways we can deal with it.
Okay.
But it's not like people who have breast cancer or colon cancer that goes into lymph nodes, and it's, could
Scary,
be
scary.
a really bad thing.
Right. Huh. So then when you say people have, and I'm so happy for you, like to have like those great outcomes, that's nice when you're dealing with disease because it's not every area, right? So when you said they have good outcomes, like great, the surgery went well and now I'm your patient and you just operated on me, what's like my future considerations? Like obviously the follow-up, but am I going home and feeling fine, or am I like sore for a little while, or?
Sure. So after we're finished the operation, like for instance, today I did 2 thyroid operations. So those patients, once we finish, the patient goes to recovery where they're waking up from anesthesia and they're observed in the recovery room for 2 full hours minimum.
Okay.
To make sure that there's no swelling in the neck, no bleeding happening, that they're able to swallow okay. It's very common to have a little bit of a raspy voice in the
Okay.
beginning
Okay.
because there is a nerve that moves your vocal cords, and
Okay.
it's right behind the thyroid. So that nerve gets moved around, and then it can be a little lazy afterwards.
Okay.
And the vocal cords, might not work perfectly in the very beginning.
Okay.
So it's common to have a little bit of a raspy voice for the first few days. And then after the 2 hours, if everything looks great, you go home. You may go home on thyroid hormone. So
Okay.
if I've removed your whole thyroid,
Of course.
you're going to be prescribed levothyroxine or Synthroid,
Okay.
which is a pill that you'll end up taking every single day.
Okay.
If I've only removed half of your thyroid and you have a normal half remaining, that may be enough. You may not need thyroid hormone. So you'll go home without thyroid hormone. And then when you do go home, we just prescribe Tylenol and ibuprofen. We don't give any narcotics. And most people have very little pain. The main thing is a sore throat that lasts for 2 or 3 days.
Okay.
And maybe some swelling. Everyone's sent home with an ice pack, and we tell you to ice it as much as possible. So we really don't have to prescribe narcotics.
That's great.
And then we see you a couple weeks later. And at that point, we have our pathology reports back, and
Okay.
then we know, was it a cancer or not?
Okay.
Will there be additional treatment? When will I see you next? And at that point, we, for the patients who've had either the half removed or the whole thing removed, that's when we test the thyroid levels
Okay.
at the 2 to 3 week mark.
Okay.
And that's when we figure out, okay, the half that's in there is doing great, you don't need thyroid hormone.
Exactly.
Or it's not making enough, we're going to prescribe thyroid hormone.
All
And then
right.
if I do that, usually then Chris or the endocrinologist is going to take it over afterwards
Okay.
and prescribe your medication for you.
And are they like worker bees for the rest of their life in your body, or do they like, hey, I used to have a buddy doing half of this work, and now I'm going to get tired after 5 years, and
No,
What
if
do you mean, does
they,
it fail? The half a thyroid? Okay.
yeah, if it's working, it continues to
it just
work.
works
Yeah,
forever
yeah.
as long as your body stays basically
right.
healthy.
Yep.
Now, what about same thing for the parathyroids? Like just lost 3 of his friends, and you cut him down to half size, so he can do the
Yeah,
job of 4
so
too.
If you remove 3.5,
Love the way you put that.
that half remaining will do the job. It's pretty remarkable.
Right? Yeah,
Mm-hmm. Yeah.
exactly.
But like I said, it's only about 5% of people that are just left with half.
Okay.
Really, 85%, I'm only taking out 1. They still have 3 normal ones. They do have a risk of this coming back, but it's only about 5% over their lifetime.
Sweet.
So most people, they're cured and that's it.
And I would think that the recovery and the side effects or whatnot post-surgery for parathyroid surgery is pretty similar to thyroid, or is it different?
Yeah, I mean, I'd say parathyroid's a little easier recovery because there's a lot less dissecting that I'm
Sure,
doing.
sure.
Yeah, a thyroid operation will take 1.5 to 2 hours, whereas a parathyroid operation, I could be done operating in 20 minutes.
Oh,
But we end up staying in the operating room
Sure.
longer because we're waiting for that hormone level to make sure we've been successful. We're
Okay.
waiting for the lab to run the hormone
Of
level
course.
for us.
Yeah.
then adrenal surgery is a whole different beast because that's intra-abdominal surgery.
Right,
So
right. But they're just one night in the
that's
hospital.
it.
Yep,
Yeah,
one
that's
night.
good.
They have laparoscopic surgery. It's just like a gallbladder. Those 3 or 4 little incisions. They have a little bit of soreness, but 95% of them go home the next day.
That's great.
Yeah.
That's great for the patients.
Yeah.
Here you go. You've been diagnosed with this disease, and like there's answers to it, and you can cure them. And it's like, thank you so much. So, one of my last questions is, when you're done with all this and the patients at home, the follow up. I know you talked about some follow up, but how long do they end up seeing you before Chris would take over from you? Or I know, is that variant
Right.
upon what type?
Right. So it depends. So if it ended up being a thyroid cancer, I follow them every 6 to 12 months
Okay.
for 5 years
Okay.
and make sure they're in the clear.
Okay.
And then many of them are also followed by an endocrinologist.
Okay.
I'm doing ultrasounds on them, making sure nothing comes back. The endocrinologist is monitoring their thyroid levels and prescribing their thyroid hormone.
Okay.
So that's a typical way of managing a person with thyroid cancer. But say you had a benign nodule, but it was big and you felt it all the time you were swallowing, and I took it out and the pathologist said, yes, it was benign, she's fine, then I would say, here's a slip, get your blood work done, and my nurse practitioner would call you with
Okay.
those results. And then if we had to start hormone or we had to adjust the hormone level, we would
Okay.
do that. And then we would get you through that initial period, but then we would have you graduate on to your primary
Okay.
care doc.
That makes perfect sense. And then, so what's been one of your most interesting cases?
Pretty on the
I
spot
mean,
now.
Well,
I
the thing
know.
is, it's not a hard question because somebody asked me the other day if I ever get bored, and because I do, hundreds of thyroids and parathyroids every year. So now I've done thousands and thousands, and honest to God, and I'm not just saying this. Every single case is different. So there's something interesting about every case. Like today, we had to do a patient who I had done a parathyroidectomy on before, a very complicated type of kidney failure patient. His parathyroid was in a totally unusual location where it should not have been. So we had to go back and find this parathyroid in a funny place.
Oh, jeez.
So there's always a twist. And so any case can be super interesting.
It sounds incredibly challenging, particularly like dealing with these,
Little grains of
glands
rice.
are the size of a grain of
They
rice.
sometimes they
Yeah.
can make you lose years on your life. Yeah. But for the most part, I that's my happy place to be in the operating room.
That's great. And it's great that we have that available in our community too. That's really a wonderful resource. So how would patients contact you if they could go through their primary, of course.
Right,
And that's
right.
likely how it occurs most of the time, or an endocrinologist that refers to
Right,
you.
right. I have most people that find me are referred by their primary care doc or the endocrinologist. But you Google, thyroid surgeon, and a few of us are going to come up in the. I'm obviously in the Providence, Rhode Island area. So a lot of people, find me that way. And hopefully I'll be spending more time in your neck of the woods.
Yeah, we hope so.
And getting
Be great for the
getting
Fall
to
River
know
community.
the community here, the medical community, and build relationships that way.
Of course. Great. Any more questions, Nancy?
No, you know what was really nice is like when we started talking about a topic, you were very comprehensive.
Yeah.
So it's nice we didn't have to really go back and
No.
like revisit any of the topics. So
great.
thank you for that.
No, it was my pleasure.
Is there any one message you want to leave patients before we?
Oh, I'd love
to a
to. Yes, I'd love to leave the message that if you are diagnosed with a thyroid problem, don't freak out about it because it's going to be fine. I have so many people.
Great
They
message.
walk into the office, they're on pins and needles. They think their world is forever changed, and they don't. They go to the internet. That's another
Oh, yeah.
message. Stay away from the internet, or don't talk to your friends either. No, talk to your friends, but I mean, you're going to be fine if you have a thyroid problem, and just seek out the proper medical care.
Great.
Great.
Don't go to WebMD. Okay. I probably shouldn't say that. But people get so nervous. They really
Right.
do.
They do. They do.
Good resource. But sometimes it gets people nervous.
Yep.
So anyway, thank you so much.
Oh,
so
thank
much.
you guys.
We really
Yeah.
appreciate
Yeah.
it.
I had a lot
Very
of fun.
Yeah, we appreciate it quite a bit. So thank you everyone for listening to our show. And if you'd like to become a sponsor, please contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music. Primacare, your trusted medical providers in southeastern New England, and BioSkills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. Bay Coast Bank, just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And of course, thank you to Dr. Mazzaglia for teaching us so much today about the thyroid, the parathyroid, and the adrenal, and the surgeries that are involved for various conditions that they develop. Thanks
Thank
again.
you. Thanks.
Thank you.
It's great. Great.
Thank you.
Thanks.